All right, David. I'll introduce David Gooch. David Gooch represents Victorian Order of Nurses, VON, and we have worked from day one. Our very first clinical pilot with complex pediatrics in the London, Ontario area, in the Southwest Lynn, started with VON at the table. VON has been a stalwart partner, clinical partner, as well as truly an organizational partner with Sensory Tech from day one, when the model was envisioned as, in its very early stage, as a concept truly around enabling nursing and extending nursing, and has seen it manifest and change in many different ways. And David's team has been there from the very, very beginning. It's been a real honor for us to work with the VON team and all of our clinical partners. We have the benefit of being able to talk about VON today and some of the work they've done. You heard about VON and their involvement with the CC2H project. And David's going to speak to you a little bit about VON and some of the other projects they're working on. So I'll turn it over to David. Thank you.
Great. Thanks, Patrick. Yes. So we'll take about 10 minutes and just talk about our journey and some of the things that we've learned and how those things inform where our future is going down the continuum with eShift. We started, as Patrick said, the first complex pediatric patient in eShift, exploring this solution to a challenging need in home care. Limited resources was really where we started with how do we enable a greater use of a limited resource, which is in-home nursing care. And then what we learned from that just really surprised us to some extent, but even though most of us who were close to it, like myself and Patrick, knew what the capability was. And so I'll just talk a little bit about that and what we see from a very service provider perspective. So you've heard the hospital perspective and the Lynn and folks, this is from the VON and what we've seen and the challenges that we face every day in home care and how this solution seems to resolve almost all or virtually all of those challenges that we currently have every day in home care. And begs the question, like was asked earlier in CC2H, is that why is it so slow to expand this everywhere? Because it is really makes a lot of sense. We expanded into our core program now, which is end of life care, starting shortly after the pediatric care, and since 2012 with the Southwest Lynn, which was the Southwest CCAC, and that still is the greatest volume of our patients. We do about 6,000 or 7,000 hours a month of eShift palliative care in the Southwest. And then brought Erie St. Clair online in November 2015, and that same population has grown significantly, continuously ever since that time till the point where right now we're doing about 2,500 to 3,000 hours every single month of eShift palliative care with tremendous outcomes. Those patients, these are patients where the caregivers need a lot of support in order for the patients to be able to stay home, and we have astounding success in doing that. And so few patients are unable to die in their place of choice. Sorry. So, as you already heard, so I don't need to go into any detail, we were the service provider partner for the CC2H program with London Health Sciences and the Southwest Lynn. We've started on another similar project with the HNHB Lynn, which is addressing that same COPD patient population, but as a community intake, that challenging partnership with primary care, and why that one is still a little slow getting off the ground. But again, it's trying to treat patients or trying to support patients like Doug before they enter the hospital, before they get to that point where they need that. And then right now, just as of February, just starting with that clinic stroke and orthopedic rehab program with Erie St. Clair. So when I wanted to talk about the challenges that we see in the health system and as a service provider, the disconnect between hospital and community. So when a patient leaves hospital, the community is a completely separate partner. It's a new intake. It's a completely different. We're virtually starting from scratch. Whether we're talking about the charting, whether we're talking about the service providers in the home, whether we're talking so much challenges for patients and for us, and a big, huge waste of big inefficient process because we go back and reassess everything. We don't translate the information that's necessary to provide good, efficient, effective care, and there is no clear or effective transition of people supporting that patient from hospital to home. The care team, like I said, changes completely. It crosses technical boundaries as well as the professional boundaries. So a completely different system in home care. It doesn't communicate with the systems that are in hospital, like Cerner and those types of things. We're on our own system, our own back office systems, and interfacing with Chris. And again, these challenges of communicating between IT systems. And different funding envelopes, so different expectations around how we're paid and how those services are costed and paid for. So we know that there's a heavy pressure to discharge patients to community, but at the same time, we're not using our clinicians in traditional home care very efficiently because, like I said, we go back out, we spend hours and hours of nurse time reassessing patients and redefining, developing care plans because it's not a seamless transition from hospital to home. The caregivers are getting burned out. You heard Doug talk about the fact that it seemed like a bit of a revolving door when we first started with CC2H of how many different clinicians were coming into and out of the home. And patients' needs are unmet, and so we do have a very high, outside of these programs, we do have a high readmission rate. We do have a high utilization of ER because we don't have that seamless transition. So we are seeing our patients, unfortunately, we see going back to hospital, or the only solution available on a particular day is to go to ER because we don't have that. We don't have the right information at the right time to be able to support those patients at home. Technology, just so people get a bit of a clearer peace of mind from a service provider perspective, this is something I've said ever since I started working with Patrick. eShift in the home is not a care tech with an iPhone communicating subjective observations. These are very well thought out, well planned, and well developed tools, forms that are measures that inform the directing nurse or therapist. I have a couple of them here today, so if you have clinical questions, they can answer them for you because I can't. So these are the things that our technicians in the home are using and providing real-time data so that those directing therapists and directing nurses are working with real live and accurate data. That is probably the largest key to the success of the program, is the real-time nature of the information and the accuracy of it, the development that has gone into it with all of those teams. So that we do end up with a dashboard that folks across the continuum of care can see, right? Whether it's the physician in the hospital, whether it's the clinician who's directing the care, or whether it's even the family caregiver can see and have access to the information, right? The directing nurse has, in this tool set, so uniquely different than anything we do in home care, where they actually have in front of them all of the information necessary, including all the contact information, all the status, and all the history of every patient. So when I spoke earlier about, when somebody asked a question about the efficiency or the ability to how many patients we can manage, what we've learned is that because when you have the right information and it's accurate and it's in real time in front of an experienced clinician, you can really expand the numbers of patients that it can be managed within one care team. And it's not a ratio of 1 nurse to 4. It's this team approach that we've developed in eShift because we have 24/7 coverage around DRNs working and directing therapists working 24/7 hours a day and working with, like I said, working in real time. So the level of efficiency that we've gained in the 8 years that we've been on this has been quite remarkable. So the last thing I just want to talk about was just a few points to just, in summary, what have we found, what have we learned as a service provider at BON through working through particularly these hospital-to-home strategies as a service provider partner in the community who's used to working with working with limited information and trying to resolve and manage patient care through a care path or a care plan that comes to us in a referral to something very, very different in eShift. So it's a unique engagement across the broader team. So we're that community service provider that's in the home, but we are engaged. The information we get is seamlessly from the very first time that the patient enters the hospital till they get home. So we are participant in the gathering of the business requirements and helping to develop those indicators because we know what we can do in the community and we know what needs to be in place for us to be successful in the home. So we're part of that process and seamlessly across. So it's a collaborative approach. One of the very unique pieces that we talked about with CC2H is that the patient in the home sees their clinical care coordinator from the LHIN, who's the same person they saw in the hospital. Right? So we as an organization don't want to create silos saying that's our patient, don't touch it. It's part of, it makes sense for that clinical care coordinator in the home to be the first patient, the first person that patient sees at home, that not only the comfort, but the transition of the information in the care plan and making sure that our folks know what's expected because of that nature of it, right? So it's very collaborative. We work with huddles every day. The planning of discharge, like in CC2H and in our new programs with stroke and rehab, is very starts at the onset, starts when patients are in the hospital and they're identified. It gives us the ability to start planning for that care at home, to do our part to support that early discharge from hospital because we can have that care plan already in place, the staffing scheduled and organized ready so that there aren't these gaps and suddenly you're ready to discharge the patient but we're not ready because we've engaged in that process early along, right? So providing real-time clinical observations, data and metrics through the dashboards, allows us to play our part in supporting the rest of the care team so that everybody has the same information. That unique 24/7 live support that Lori talked about, that started in CC2H, and now we utilize it across all of our eShift programs. Our DRNs can support any patient, whether we're in the home at right now or not, because we have access to the information. So that 24/7 piece provides an awful lot of direct support and creates a lot of opportunities to avoid having to go to ER, working with the COPD patient, working with the palliative family at home who's running into a real stressful situation, and avoiding that normal answer, which is send them to the ER. So we don't do that, and we rarely send folks to ER, and almost never in our palliative program. So real-time clinical reporting, 24/7 live clinical administrative support for our patients, around our patients, and a full team that's actively engaged as a project team for engagement from beginning to end, both from design to redesign to continuous improvement of those programs. So that's really all I want to talk about from the service provider perspective.
Thanks, Dave. We have some questions actually before we get into
Yeah, David, I think this is the obvious, but probably our Achilles heel in the community is our ability to help the right human resources, right? I'm well aware of that, you're well aware of that. Do you find, because we're always trying to create ways to have a workforce that's engaged, are you continuing to find that your technicians, whatever you want to call them all, that there's more appetite for people to want to be a technician versus some of the other routine care that they would provide?
There is, but I can tell you from our recent observations, one of the things that we're learning is that there's a real healthy appetite, desire on the part of PSWs to be care technicians for the palliative care teams and for the pediatric care teams. The nature of that work, their comfort level, their comfort level with the activities that we're asking them to do is very high. They're very engaged in being willing to take direction from a nurse and doing what they see as nursing activities, so it's a career improvement. But the real learning has been using therapy assistants in rehab, and that group is really engaged in that work, and I think will actually become the future for us in how we manage the CC2H patients, because that group is more adept at working with that patient population. So that right fit between the worker in the field and the type of patient will help us over time resolve some of the staffing situations that we are still having.
Yeah. And Patrick, I'm not sure, are you talking later about the research that Lori Donnell's group ran out of BWO?
So, no, just because of the time.
Okay.
So actually, this is actually a perfect segue, if I may. So VON, if you could put your hands up. Okay, nice and high. So when we step out, we have one session left, and when we step out, so I'll preempt that by saying before we start the cocktail reception, we're actually going to introduce certain groups. Some of you will absolutely want to go around the corner and actually see what eShift looks like when it's operating, what the clinicians are doing. And I would ask that if VON staff wouldn't mind when they get their wine and stretch their legs, if they wouldn't kind of gravitate to that area, because we're going to be showing essentially the things that team is using on a daily basis, and they'll be able to provide much better context than our team would when it comes to non-clinicians giving these demonstrations and talking about it. And there'll be an excellent opportunity for you to meet VON staff that are actually utilizing the tools and voice over what we're actually showing you. I think it'll be a great opportunity to talk about that. From a research perspective, there is more than one academic team in the room today. We have UK academia here. Please put your hand up, Professor Mawson. And there's been published research around what's been happening with eShift in the United Kingdom and the outcomes that have been seen in models of care that are very different from the ones that we've looked at here. Different in the sense that instead of nurses and nurse assistants or technicians or therapy and therapy assistants, it's actually been medics, physicians, the equivalent to nurse practitioners, working with what we would consider RPNs and RNs. So truly peer allied health professionals working in a group setting under very complex palliative care environment, providing interventions that would normally never be done in the community, let alone by a subordinate team member. So there's some very interesting aspects there. And then we have Lori Donnell and team's Western research information to share as well. I will be happy to pass into the introductions there. So from a couple of things maybe we could just touch on to end up with VON. I mean, organizationally, and this would be open to the VON team, the staffing model is unlike anything you normally would, I would say normally, it's become normal now, that you've historically ever done. Was it something that took a massive change for you structurally as a nursing organization to set up and do it, or did it seem like a natural fit? That's an open question.
Janine?
I think it's something that has been kind of evolving over time, and which, we started out with a small group.
Yeah.
And then from there, the word has kind of went out into the community, and that's what a lot of the staffing is that friends know, our coworkers, and they've come into eShift, have done the program, have really enjoyed it. Community healthcare, that's 4 year end, and now they've spread the word out, and we've gotten more interest in our program. And like we were saying, with the healthcare tech, I've been involved with them, as well as the DRMs from the very beginning, doing education, supervising, and now managing them. And they enjoy it. This is their passion. They're opening up that scope of practice and doing more things. They're acting as eyes, hands, and ears for the registered nurse. So they love their job, and our retention is great because of that aspect of it as well. So we continue to keep growing and growing and taking on more populations as well as our
It's interesting for me in the non-clinical perspective and looking at the business model behind home care. And in many cases, we were talking about the patient populations, palliative and pediatrics, what we end up seeing built are essentially virtual facilities, right? So you've got the teams that David's organization staff become functionally somewhat static teams that are essentially deploying virtual beds. They're not their own beds, they're your beds, right, out in the community. And those teams are basically deployed geographically. And we've seen, in Ontario alone, we've literally seen hundreds of concurrent beds being staffed by these virtual teams, replicating exactly what we would have done in an institution. So we can actually now say, wow, we've got the world's largest hospice, or we have the world's largest particular of one type of ward, where you can talk about a 100-bed ward of something. It's been fascinating for us to see organizationally how the nursing agencies have stretched and reorganized themselves to essentially become truly the virtual staffing arm of these virtual wards as they build out. And I think we're going to see another couple of significant evolutions over the next couple of years, and in alignment with what Lori Gold was talking about, with a major hospital system going out and saying we are now going to put our standards, our best practices across your staff out into the community, and there's going to be this trusted link between the two of us, and we're going to be able to collectively move the patient through symbiotically and be able to, from a patient perspective, whether they're getting cared for in the third floor back corner or they're in their own home on the first floor, receiving the same perspective care. So it's an amazing thing to see happen. So thank you very much, David. So